So the next presentation will be given by Dr. George Washko from Harvard University, who I met for the first time this morning. So I'm looking forward to hearing his presentation, and thank you for coming. I should mention that the top 3 centers in the world for COPD-related research, in no particular order, are Harvard, Imperial College, and UBC. And we've got the big hitters here today who've contributed to that. So here's another big hitter. So thanks very much, George.
Thank you very much for that introduction. Thank you. And certainly it's a pleasure to be here today. Thank you for the invitation, and it's an honor to be part of this awards ceremony. So I'll start with the disclosures here. You see my consultancy agreements, and I also have to disclose, and this is probably cost me some of my greatest thanks, is that my wife works for Merck, and that leads to all kinds of disclosure issues in clinical studies or something. But she is well worth the so he's on camera. So why do imaging, right? Well, what we really want to do, we want to understand the pathophysiology of disease. How is lung structure related to the clinical manifestations of the process? We want to reduce the heterogeneity of disease. You see 2 people here who may be spirometrically indistinguishable, but clearly they are different. How do we leverage imaging to look at that? And finally, how do we use imaging for biomarkers to study endpoints? Can we design intermediate study endpoints, more sensitive measures of outcomes? We can reduce sample size or cost. Is it cost? Do you want me to switch to?
I think you're just a little soft-spoken.
Okay, perfect. Okay, I'll lean closer. Is that better? Perfect. So over the course of the next half hour or so, I'll be talking a bit about imaging and the parenchymal abnormalities, the airway disease, vascular disease, and finally we'll touch base briefly on the extrapulmonary manifestations of smoking. For, after all, COPD is a syndrome, and imaging will certainly be leveraged in that component as well. Now, the objective assessment of emphysema has been a point of interest for over 3 decades, and much of the work in this field had been pioneered locally, even by people here in this room. The method that I have shown here is called a densitometric analysis, and briefly, the lung is segmented from the surrounding chest wall. We then create a histogram distribution of densities or CT attenuation values within that lung. And we then pick a threshold to dichotomize the lung into disease, emphysema, or not disease, not emphysema. This can be expressed as a fraction of emphysema, or percent emphysema. And really, this has become the workhorse of clinical epidemiologic and genetic investigation. There have been several advancements now looking at pattern recognition, textual analysis, and I'll touch base on that briefly, but still this is really the benchmark that people use. Now, in looking at clinical applications, there is quite a bit of interesting data out there already showing the utility of imaging in COPD. These are data now taken from a Japanese cohort, almost 300 people, 279 with COPD, and they had baseline CT scans, and you can see they were followed spirometrically every 6 months for up to 5 years. And what these authors found is that at the end of the 5 years, there were 3 distinct groups: the sustainers, the spirometric sustainers, the ones who had no real decline in lung function over the period of observation, the slow decliners, and then the rapid decliners. These people were all spirometrically indistinguishable at baseline. And the only distinguishable characteristic of these people at enrollment was the CT score, the percent emphysema. What I'm showing here is a visual score, but that was actually recapitulated with the densitometric analysis. The rapid decliners had more extensive emphysematous destruction of the lung at enrollment. We don't know the mechanism. We don't know where these people fell from as far as their baseline lung function, but there is something with radiographic emphysema and rate of decline in lung function. Similarly now, CT scanning is being used in clinical investigation. A great example here is in augmentation therapy for alpha-1 antitrypsin deficiency. These are the results of 2 randomized placebo-controlled clinical trials. they have the augmentation group here and the placebo group here, and they were followed longitudinally looking at baseline and follow-up CT scans. And as you can see, there was a significant decrease in the amount of tissue lost on CT scan over the period of observation in the augmentation therapy group. And again, I don't know if this would be spirometrically detectable, but it's highly statistically significant using the CT imaging. Again, we may be finding intermediate study endpoints, and this is certainly under evaluation now by the FDA to see if you can register a drug using this measure of disease. Now, CT is great for lung structure, but there are several complementary imaging modalities that provide excellent insight into function. And one such example is the picture I've shown here is PET, and this is actually FDG was the radiotracer looking at neutrophilic activity in the lung. This is an image taken from Dr. David Parr's group in the UK, where they were doing PET scans and serial PET scans on smokers with both garden variety COPD and also alpha-1 antitrypsin deficiency. This happens to be more of the garden variety COPD, upper lobe predominant emphysema, and you can see when correcting for the underlying lung density, the greatest radiotracer uptake, the greatest neutrophilic activity was in the apices of the lung. If you then look, and we'll go first here to the right-hand panel, this is another densitometric measure of emphysema. Those with the greatest amount of emphysema on CT scan had the highest FDG uptake when normalized for underlying lung density. There's something about the lung tissue, the neutrophilic activity, there is more inflammation there. And similarly here looking at the FEV1, the lower the FEV1, the greater the upper zone FDG uptake, and this is in the garden variety COPD. So this really begs the question of, are we looking at now another intermediate study endpoint? If we are focused on inflammation and neutrophilic inflammation, can we use PET, an FDG PET, as an intermediate study? If we reduce radiotracer uptake, can we actually mitigate the disease process? Can we attenuate the decline in lung function? There's a lot of work that has to go into that, but this could be the promise of this type of technology. Noble Gas MRI. Now, this is a tool that is I think, really perfect for doing lung research. It provides exquisite, detailed assessment of lung structure, but also, depending upon the contrast agent you use, function. These are data now using hyperpolarized helium, a gas that's not diffusible across the alveolar capillary membrane. And these data taken from 2009, we're looking at a series of patients, the normals and then those with more progressive COPD. And two things I'd really want to point out are data here on the mean linear intercept and also the surface to volume ratio. So as we inhale this gas, we then start doing our scanning, and the architecture, the underlying microarchitecture of the lung provides constraints by which these molecules can bounce around. Now, through fairly complicated analysis, you can start to divine the underlying lung structure. And if you look here, the mean linear intercept is essentially normal in this person, and then progressively increases as you come down to the more severe COPD. And inversely, you have a reduction in the surface to volume ratio with more severe COPD. And this is, I think, the most enviable R-square I've ever seen in investigation. But the association of imaging, this is the MR estimates, and the histopathologic estimate or measurement of LM was 0.985. That's the R-square. 98.5% of the variance was explained by that. Amazing. Now, more recent data, and this provides, I think, some exciting insight into the potential for the lung to grow or change. It is a very dynamic organ. And this was actually a patient who underwent pneumonectomy at our hospital several years ago. She had cancer, the lung was taken out, and then in the ensuing years, she had serial CT scanning of her chest. And what her surgeon, and this was Dr. Menzer, had observed is that her remaining lung seemed to be growing over time. And the question really was this mechanical deformation of the lung, or was this some other compensatory process in the lung because of the pneumonectomy? And what the authors did ultimately is they had her undergo helium MRI, and they found that the mean linear intercept and the surface to volume ratio was essentially normal, and further was fairly homogeneous across the lung. So it was not like the lung was distorted and hyperinflated. It just looked like there were more normal lung tissue. And this certainly requires a lot of replication, but it does suggest that there may be the potential for lung growth in adults, which is a radical concept for sure. Now, we all appreciate that there's different patterns of emphysema, and we believe that there's different clinical, epidemiologic, and genetic factors associated with this. We have our standard, as Jim had shown earlier, the paraseptal emphysema. We have a panlobular emphysema, or complete effacement of the architecture. And down here, the central lobular emphysema. And what we've been working on now is a tool to classify that. How do we move past conventional densitometric analysis to actually do a relatively parsimonious pattern recognition? One of the problems with doing a detailed textural analysis of the lung is it's computationally very costly. And we want to do this in large volumes of scans, and that's impractical at this point for clinical investigation, given the limitations of equipment that most centers have. So we based our research really on the local density or the local histograms. And the majority of the feature recognition or the discriminatory ability of a pattern is really in density. And we classified types as the non-emphysematous tissue, mild, moderate, severe, central lobular disease, panlobular disease, and then this was a pleural-based disease, which is a bit of a catch-all, and we certainly need to do some work there. But you can see an example here of the color coding classification that we applied, and this was across CT scans in the COPD gene study. And what we found, and it was actually very exciting, it's rare that things work out like you'd expect them to when doing investigation. These are data now from the full 10,000 people enrolled in the COPD gene study. We have the smokers with normal lung function, the GOLD 1 through 4 disease. The non-emphysematous tissue, as you might expect, declines with disease progression, or again, this is a cross-sectional study, so in more severe disease. Mild central lobular, moderate central lobular, and then the severe and the panlobular disease. It makes sense, and I think we're starting to get some insight or inferences as to how emphysema may progress. Is there a coalescence of these holes where a small pocket becomes larger pockets? What's the de novo formation of emphysema in the lung tissue? Again, a lot of work to be done here. We're now rescanning people in the COPD gene, and it'll be great to see how these measurements progress over a period of about 5 years. Now, imaging certainly has provided insight into the divergent response of the lung to noxious stimuli, such as tobacco smoke and other things. It's not debatable at this point that smoking leads to the development of COPD, but it's increasingly clear that smoking also leads to interstitial lung disease. And these really are extreme manifestations of the process. And so there must be now this group, this overlap, subpopulation in the middle. Who are they and how do we characterize them? So what we did is we went back and we looked at about 2,500 people in the COPD gene study. We did a manual review, a visual review of all the axial images. And we found certainly there were the extremes, the bullous emphysema. There was a small handful of people who had frank pulmonary fibrosis on CT scan. But then about 8% of the population of smokers in this cohort, they're all smokers, current or former, had these interstitial abnormalities on CT. Those people, that middle ground, had less emphysema on their CT scan, had lower lung volumes, and actually for a given amount of lung dysfunction had decreased exercise capacity as assessed by the 6-minute walk test. Now, what we don't know is what becomes of these people. Do these people regress? Do these people go here? Do these people go here? But certainly in the pulmonary fibrosis community, what would be great is to find an upstream cohort of people that you can enroll in clinical investigation. Sadly, right now, pulmonary fibrosis, especially IPF, is an untreatable condition. You can ethically use a placebo-controlled study because nothing works. If we can find the upstream cohort, maybe we can intervene before this becomes an irreversible condition. Maybe we can leverage these people. Now, as I mentioned, we don't know yet what becomes of this cohort, and the longitudinal studies are just going on now, but we actually then turn to genetics to see if we can find some similarities between this cohort with the interstitial lung abnormalities and this group with the pulmonary fibrosis. So what we did is we looked at a large group of people in the Framingham Heart Study. This is essentially a population-based study that was started in Framingham, Massachusetts in 1948, and people have been followed serially. It's on to the third and I think even the fourth generation right now. And there's a polymorphism in the MUC5B promoter that has been strongly associated with idiopathic pulmonary fibrosis. And what we sought to do is determine, were there similar associations between this polymorphism and this radiologic abnormality. This is a preclinical state. This is a radiologic phenomenon. And so we performed a visual analysis of all of the Framingham cohort, the volumetric and the cardiac CT scans. And what we found was that 9% of the group over 50 years of age had these abnormalities. And this is it was strikingly similar to what we saw in the COPD gene with 8%. But it was amazing that there was no relation to smoking status. We thought for sure coming out of COPD gene it was a smoking phenomena, but there was no relationship here between the smoking status and the development or the presence of ILA. It was all an age phenomena. Very few people under the age of 50 had this. And what we found is that for each copy of the variant, never smokers had more than double the odds of having ILA. Now, this is a very common polymorphism in the general population. It may suggest that the at-risk cohort for the development of pulmonary fibrosis could be 1 or even 2 orders of magnitude larger than what we classically think of. And there might be a lot more pulmonary fibrosis in the community than we appreciate. So on to the airways. So we'll start really with the easiest to recognize, and that's bronchiectasis. And these are data that came from the East London study, 54 patients with COPD who had CT scans, had diary cards. And the authors went through and performed a detailed visual analysis of the CT scans and found that 50% of these patients, 27, had bronchiectasis more commonly in the lower lobes. The presence of bronchiectasis was associated with a prolonged recovery from exacerbations and also higher levels of sputum inflammatory cytokines. Now, in a subsequent, this is a larger study, a little over 200 patients, and this was just published this year. They found that 57% of the cohort had bronchiectasis on their CT scan, and that bronchiectasis was associated with increased risk of death, and you see the hazard ratio here. Clearly, you do not want to be the group that has bronchiectasis on CT scan. So a lot more work needs to be done here, but again, we're identifying subphenotypes of people that may have or may benefit from more targeted therapies. Objective analysis. So this has really been something, again, that was pioneered here locally, very similar to the densitometric analysis of the lung parenchyma. And what investigators have been doing are making measurements of the central airways and drawing inferences from that for distal airway structure. And there were a beautiful series of papers that outlined this. And beginning in 2000, Dr. Nakano and the group measured the wall area and the lumen area of the third generation airways, the apical segment right upper lobe, and found that those with the greatest wall to lumen ratio had the worst lung function. The same group then came back in 2005 and showed the relationship histopathologically between this measure here and the distal small airways. Greater wall area thickening here, more small airway disease histopathologically. And finally, in 2006, Dr. Hasegawa and the group looked at successive generations and found that objective measures of the airways were associated in increasing fashion with lung dysfunction. You had a higher correlation coefficient going from more peripheral to more central to more peripheral airways. As you approach these small airways that were defined as the site of airflow obstruction, you got better and better insight into lung structure. Now, this has really led to an undercurrent in the imaging community. Everyone's battling. I've measured the 7th generation. I've measured the 8th generation airways. But there is something compelling here to these data. Now, I have to admit that I thought at least part of that was noise or artifact, really to do with the limits of resolution of the CT scanning, but Dr. Coxon proved me wrong here in 2008 using this technology, optical coherence tomography. And it's a technique that provides resolution on the order of microns. And what he found was that the airway wall, the wall to lumen ratio, was associated with lung dysfunction. And again, as you got more peripheral in the lung, these associations with lung dysfunction increased as seen on CT scan. And I think there's a lot of promise for this technology because not only can it more accurately see wall thickness, but you can look at inflammation, remodeling, and fibrosis. So there's certainly more to come from this technique. Now, we classically think of COPD as coming in two flavors. We have emphysematous destruction of the lung parenchyma and remodeling of the airways, small airway disease. And it's increasingly clear, and we've already heard some today, that this is not the case. And this is an example of a volumetric reconstruction of a normal lung and a subject with severe emphysema. And you can see clear differences in the number of airways visible, at least on CT scan. And this is now the paper that Dr. McDonough in Jim Hogg's group put out in 2011, looking at the association of airway loss or airway dropout in lung dysfunction in COPD. So successively higher gold stages of disease, these are subject who underwent surgery for a variety of causes. Using micro-CT, they demonstrated very nicely that there was a significant decrease in the number of small airways in successively higher gold stages. But this was not only constrained or limited to the small airways, but was recapitulated here in the central airways. And this is the third, fourth, fifth, sixth, and seventh generation. You see significant decreases in the airway count of the central airways on clinical CT scans. So you're losing cartilaginous airways as well, not just the very peripheral airways. And as you can imagine, having a phenotype of airway loss is probably not something that's amenable to bronchodilator therapy. So again, we can start to think about how CT imaging and other techniques may help guide or direct treatment. On to vascular disease, and this is something that we've been quite interested in. And the estimated prevalence of clinically relevant pulmonary vascular disease in COPD ranges from 1/4 to 90%. They vary wildly. And actually that's very exciting because it means there's an opportunity and no one really knows what to do with it. And it has been demonstrated that those who have it, they cost more and they're more likely to die with it or from it. And we've seen, and again, this is from Juan Albert and other groups locally here, that even in smokers with normal lung function have pulmonary vascular remodeling on histopathology. And if you look at, well, so what's the clinical meaning of this? And this is a nice study that Mike Wells put out recently, looking at data from the ECLIPSE study and also the COPD gene study. About 75% of exacerbations are viral, bacterial, or some combination in etiology. But about another 25% are inhalational injury and also cardiovascular associated. And so what Mike's question was, is a standard radiologic measure of pulmonary hypertension, the dilation of the main pulmonary artery, how does that relate to acute exacerbations of COPD? And what he did is he measured the diameter of the main PA in the aorta in a single slice, and then we looked at both three models: historic exacerbations, so exacerbations reported in the year prior to CT scanning, as well as prospectively, how does CT predict exacerbations? And in all cases, the PA to A ratio, the ratio of the pulmonary artery to the aorta, was highly statistically significantly associated with both historic exacerbations as well as prospective exacerbations. And in some cases, it was even stronger than the most compelling factor, having exacerbation, basically asking a patient if they had an exacerbation. So there is something of interest here. The question is this disease severity, is this pulmonary hypertension? We don't know, but I think it's certainly a place to start. And as I mentioned, we're very interested in the parenchyma, and here the intraparenchymal pulmonary vascular morphology, and looking at things like vascular pruning, elongation, deformation because of emphysema, change in the branching angle. And if we can see it, we want to measure, we want to objectify it. So what we've been working on now, and these are figures taken from the COPD gene study, volumetric CT scans done without contrast. We've done a three-dimensional reconstruction of the intraparenchymal pulmonary vasculature here in a normal and in someone with fairly significant upper lobe, upper zone predominant emphysema. And we've been exploring the different metrics or measures of these abnormalities that we see and their clinical relevance. And one of the things we've been doing is plotting the vascular blood volume as a function of cross-sectional area. So essentially getting a histogram distribution of the blood vessel volume. And what we found is that in more severe disease, most typically more emphysema, you had a decrease in the distal vascular volume, distal pruning, and what you can't see here is even slight increases in the more proximal vascular volume, as if you have reductions here and compensatory dilations more proximally. And so we're working on all the different clinical associations of this, and this is definitely a work in progress. And then the next logical step is once you have the airways, once you have the vasculature, can you marry the two and actually look at bronchiectasis? And this is just some preliminary data that we have. We have people who had no evidence of bronchiectasis on CT scan, and a subject who clearly had bronchiectatic dilation of the airways on CT. We plotted the airway radius to vessel radius here, the ratio, as a function of cross-sectional area of the vessel. I'm sorry, here this is actually vessel radius. And in looking at those vessels of greater than 10 millimeters square in cross-sectional area, the normal lung, generally all ratios are less than 1, which is about what you'd expect. And those in this person who has bronchiectasis, there's all these spikes that come above that ratio of 1, as if you have ectatic regional dilation of the airways as compared to the adjacent vessel. And we're looking at now the mean value of these spikes as well as the standard deviation and their clinical utility, their association with things like mortality, exacerbations, all these other things. Now, body composition, I promised this, and this is the last aspect of the talk. And how do we leverage imaging to really get a better understanding of the cachexia associated with this disease? And this is actually a great study. It's a little over 10 years old. They looked at, authors looked at 142 subjects with COPD, had all these independent covariates that were predictors of mortality in their cohort. And they then dichotomized the measure of the mid-thigh muscle cross-sectional area obtained on CT scan into those above or below the 70 centimeters square, and found that after multivariate adjustment, both this radiologic measure and the FEV1 were still highly statistically significantly associated with mortality in COPD. And you can see what you don't want to be is the skinny person with bad lung function, right? You want to be up here, the bigger person who has relatively preserved lungs. And so not all body composition is the same. We need to look at fat and different fat depots in the body, as well as skeletal muscle and the fat-free mass to better understand how this relates to outcomes in COPD. So in summary, again, COPD is a syndrome. We can certainly look at all the pulmonary manifestations of disease, but imaging also I think is very powerful to look at the extrapulmonary manifestations of this process. And I think it can reveal things that are spirometrically silent. Imaging won't replace all the things we've heard about today, but I think it can be complementary when used judiciously. We don't want to irradiate everyone just to get CT scans. But certainly there are cohorts that are coming through. Everyone is getting their lung cancer screening CT scan. Can we start to process that and squeeze more information out of it? And certainly imaging is already being integrated into clinical investigation, and I think it is here to stay. All right. Thank you very much.